Dear ladies and gentlemen, dear colleagues, good afternoon. It is my great pleasure to be with you. I hope that you hear me loud and clear and that you can see me. And we can start our webinar. The title is How to Manage Pain in Our Clinical Practice. Let me first of all show you a few images of my hometown Belgrade, which has the best nightlife in Europe, they say. I have no experience, but if you come here, maybe I can join you. And this is Institute of Rheumatology where I work. This presentation is sponsored by Gedeon Richter. Everything what I plan to say is going to be evidence-based and independent from financial or any other influence or interest. So, first of all, tell me, what do you think? Is this dangerous or not? Well, whatever you think it is, it could be dangerous, but hopefully it is not. But you know, they say the dog actually is the best man's friend. And I believe many of you think that way. However, scientists used to say that pain is the best man's friend. Because pain is actually an alarm for our body, and it says that something is wrong and that we should take care about it. However, chronic pain is also a big clinical problem, and we have to deal with it. And it is associated with a lot of rheumatic diseases, as you very well know. So, how do we generally manage pain in our everyday clinical practice? We use paracetamol, non-steroidal anti-inflammatory drugs, opioids, morphine, and non-opioid analgesics. This is where some of these drugs work, at which they work in different level of the pain level. And but we won't go in details in these levels. I will just show you the World Health Organization ladder of pain treatment. And as you can see at this ladder, apart from adjuvant treatment of pain, at first step, World Health Organization is recommending paracetamol and or non-steroidal anti-inflammatory drugs. Then the second step is that we should add weak opioid if this first step doesn't work. The third step is considered to change to strong opioid for moderate to severe pain, or to go to morphine. So, which steps do you use in your everyday practice? And I will today focus mostly on paracetamol and NSAIDs, and I will mention paracetamol and opioids at the very beginning of this talk. You very well know that efficacy, meaning effectiveness actually, the value of any drug depends on its efficacy and its safety. So let's see briefly what is the efficacy of some of these drugs for the pain treatment that I mentioned. And here we will have the comparison of many studies regarding the efficacy of paracetamol, non-steroidal anti-inflammatory drugs, and opioids. And then let's see the result. As you can see here, in the upper part of the screen, there is an average efficacy of acetaminophen, which is practically paracetamol. And at the same time, you have an average efficacy of oral NSAIDs. As you can see, this average efficacy of different trials is very similar. Let's go to another screen where we again have paracetamol compared to COX-2 selective inhibitors. And as you can see again, efficacy is quite similar, with COX-2 selective drugs being a little bit more, but not significantly better efficacy than paracetamol. I have to warn you that here high doses of paracetamol were tested. It was 3 to 4 grams of the drug per day. Now we have paracetamol in comparison to opioids. And this maybe is a surprise for you, because probably many of you thought that opioids are with much better efficacy than paracetamol. But as you can see here, it's not the case. Now let's go to oral NSAIDs and opioids. And you will see that average line of efficacy is practically almost the same, very similar. So, COX-2 inhibitors and opioids, again, very similar efficacy, a slightly stronger efficacy of COX-2 selective NSAIDs, which is a little bit surprising for some of the doctors who were not aware of these results. Now, this is another study where paracetamol was compared to different NSAIDs, and it was seen that these NSAIDs, in this case it was itracogtib and diclofenac, were significantly better than average dose of paracetamol that is used in everyday clinical practice. And that's not surprising because we know that. And again, this is treatment of physical disability, and diclofenac and itracogtib were much better than paracetamol, which was expected more or less. Now, efficacy, as you can see, we can say it's quite similar, despite the opioids are second or even third step in the treatment after paracetamol and NSAIDs, which is a little bit surprising. I agree with some of you at least. Now, what about the safety of these drugs? Let's go to safety of paracetamol, and we will speak about safety of doses which are 3 up to 4 grams per day, which are similar with, regarding efficacy with NSAIDs. Now, paracetamol expresses its toxicity at different levels. However, liver is one of the biggest problems. And in this, you can see the black areas of liver, which are actually areas of dead cells. Red areas, which are areas of monocyte infiltration, and blue areas, or green on your screen, which are areas of vivid live cells. As you can see, after several hours, the black area is hugely increased. So paracetamol is quite toxic for liver cells. Now, these are the average rate of suicide and the highest line with rounded dots is the line of non-poison suicides. The second one was antidepressants, and the third one is paracetamol, different compounds with other drugs, and the fourth line is paracetamol alone. So as you can see, paracetamol in different combinations is on the third and on the fourth place regarding the mortality rate in England and Wales. Unfortunately, it is very popular to commit suicide with this drug. Now, what about opioids? These are data from Ontario. And as you can see, the rate of deaths is significantly increasing in previous 20 years because the use of opioid is increasing dramatically in North America. Next data will be from United States. And as you can see, the same trend with huge increase in number of deaths, starting from about 12,000 in 2002 to close to 50,000 in 2017, which is a huge number of people. And we have much more that are addicted to these drugs. And this is a huge problem today, and there is a huge campaign to reduce the use of opioids in the United States. So these drugs are dangerous, and that's what we know. What about the comparative efficacy of NSAIDs themselves? How they work, and are some of them much more effective than the others? Well, if you can see the average efficacy of the full dose in different trials, you can see that the range of efficacy of different NSAIDs is very similar. There are no major differences. Now, again, the major question about the value of different NSAIDs is how safe these drugs are. And that is why we will talk about safety of NSAIDs. And you very well know that different organs and systems could be affected by the toxicity of NSAIDs, and we can have different problems. And among these problems, the gastrointestinal bleeding or obstructions or perforations and cardiovascular adverse events, first of course, myocardial infarction and strokes, are one of the most important problems. Now, how we can manage the risk of NSAIDs? First of all, this risk depends on patient and his disease, meaning that it's very important how patient is old, does he has any risk factors for the GI bleeding or cardiovascular disease, and so on. Then next thing that is important is duration of treatment, then dose of the drug, and then of course if we can use the safest drugs. And which are the safest drugs, we will discuss a little bit later. So let's start first with a patient. Now, how the safety is dependent on a patient and on a disease, of course. First of all, if we treat chronic inflammatory diseases like spondyloarthritis or rheumatoid arthritis, we all know that these patients, particularly spondyloarthritic patients, are young, in their 20s, 30s, or 40s. And the rheumatoid arthritis patients are of average age, meaning that we do not have so many elderly patients. Therefore, the safety of NSAIDs should be better than in average population, or let's say in elderly patients that are suffering from osteoarthritis. Let's see, this is a very interesting analysis, one of the best in the world, that was done through the Swedish registry, and it covered 22,000, practically 22,000, a little bit less than that, patients with spondyloarthritis. And the question was simple: are those who are using NSAIDs, are there non-selective NSAIDs or COX-2 selective drugs in comparison to those who are non-users, have significantly higher number of adverse events? And to make the story short, overall, you can see the conclusions here from the study. You can see that overall serious adverse events related to non-selective NSAIDs and to COX-2 selective drugs were similar and in range that would be expected in the group of spondyloarthritis patients, without even significant difference in comparison to those who were not treated with these drugs. So generally speaking, safety of non-steroidal anti-inflammatory drugs, either selective or non-selective, is generally good in spondyloarthritis. Now let's see one other interesting analysis of close to 1,000 patients, actually 923 patients, which were followed, which all of them had chronic arthritis, and all of them were followed for 10.7 years, practically 11 years. And the risk of early death, premature death, was calculated. So what happened after these 10.7 years? Who lived shorter? Those patients who were taking NSAIDs or those who were not? As you can see, here is overall mortality, and green bars are the mortality risk of those who were treated with NSAIDs, and violet bars are risk of mortality for those who were not treated with NSAIDs. As you can see here, actually those who were chronically treated with NSAIDs had lower risk mortality. And then I will show you cardiovascular risk mortality. Mortality risk of cardiovascular causes. And you will see even the higher difference. So the risk of mortality, early premature death in those who were chronically treated with NSAID was more than half lower than in those who were not treated with NSAIDs. Now the question is why? I'm so sorry that we cannot communicate. I cannot hear you. I hope you can hear and see me. If we could communicate, I would ask you why. But I'm sure that many of you know the answer. The answer is very simple. And in one word, it's atherosclerosis. In those patients who have chronic inflammatory disease lasts for years or decades, the acceleration of atherosclerosis is significant. So atherosclerotic process is much faster than in those who do not suffer from chronic inflammation. And therefore, if we can reduce the inflammation, we can reduce the speed of atherosclerosis development and increase the life expectancy in these patients or persons. And that is why, if we treat with NSAIDs, we can even increase the life expectancy of our patients with chronic arthritis, with chronic inflammatory disease. And the same results were observed in this publication, in this study, where non-users of NSAIDs were compared to users in patients with chronic inflammatory disease. And it was seen that either we use non-selective NSAIDs, so total NSAIDs, or we use COX-2 selective inhibitors, these drugs, both of these groups, actually are protecting in a way patients with ankylosing spondylitis from cardiovascular adverse events. So again, the same story. Treatment with NSAIDs could prolong life and could actually protect people from cardiovascular adverse events, which are most probably connected with atherosclerosis. So that is the story, which sounds quite good for the patients with chronic inflammatory diseases. What about the elderly patients who mostly suffer from osteoarthritis? Now, is it bad to get old? Well, as Maurice Chevalier used to say, it's not so bad if you consider the alternative. And I hope for all of you, and including me, of course, that we will face the alternative as late as we can. So, what is about the osteoarthritis in these patients, and what about the risk factors of GI bleeding with the use of NSAIDs in patients with osteoarthritis? This here is the table of risk factors in 17,000 patients with osteoarthritis. And as you can see, 76% of them were older than 60, which is one risk factor for increased risk of GI bleeding. Then about 1/3 of them had dyspepsia, another risk factor. NSAIDs plus aspirin was also present. High doses of NSAIDs, NSAIDs plus anticoagulants, which is very dangerous. NSAIDs with uncomplicated ulcer, NSAIDs plus glucocorticoids, which is also an important risk factor, and complicated ulcers, which are very big risk factor. So, as you can see, just 7% of them had no risk factors. About 27 has one, 37 had 2 risk factors at the same time, and cumulative 28% has 3 or more risk factors at the same time, which is quite high. And what put these patients in high risk of GI bleeding? First, GI bleeding history, previous GI bleeding, and it was present in 3% of these patients. Anticoagulants with NSAIDs, close to 13% of these patients had that therapy. And the risk factor plus ulcer, simple ulcer, was 12%, and presence of 3 or more factors at the same time was about 28%. In total, it was 56% of these patients that has high risk of GI bleeding when they are treated with NSAIDs. So we have to take care of that, and we have to use the safest possible way to treat these patients. Now, what about the cardiovascular risk? Do you maybe recognize yourself on this cartoon? Do you have time to practice? Or you just work, like myself, most of the time? I hope you're better than me and you have time to exercise, so you won't get in this category which is presented in this cartoon. However, individual NSAIDs and risk for hospitalization of heart failure is very interesting table where we can see, actually graph, where we can see which drugs are the safest regarding the potential heart failure with the use of NSAIDs. As you can see, we have here the aceclofenac, meloxicam, diclofenac, proglumetaset, flurbiprofen and celecoxib, and they were as safe as placebo. Valdecoxib, nabumetone, and others were more dangerous. And we have below the celecoxib, we have some other drugs, but there the standard deviation was too wide, so we cannot count them. But as you can see, starting from aceclofenac and other 5 drugs that we have here, they were all almost as placebo. Particularly aceclofenac, meloxicam, and diclofenac in low dose. That means that these drugs were very safe. The others were not so much. And all these drugs mostly are mild COX-2 selective drugs, which is very important. Now, what about the dose? I think you all know that story is relatively simple and quite scary. So, green lines are low dose of different NSAIDs and red lines are high dose. And as you can see, for very different NSAIDs, if we use low dose, the risk could be quite low, like for ibuprofen, for diclofenac and others. However, if we use the highest approved dose, then the risk is usually increased up to 10 times. Here is the risk of GI, upper GI tract bleeding. So risk of bleeding is highly associated with the dose of the drug. Low is the dose, low is the risk. Now, what about the treatment duration? Story is very similar as with the dose. Let's see here. Here we have 2 drugs, one highly COX-2 selective, another one is non-selective considered, though it could be mildly COX-2 selective in some tests, and it is. However, as you can see, there is no much difference in first 2 years of treatment between these 2 drugs. However, for both drugs, you can easily see that the cumulative incidence of adverse events is significantly and constantly rising with the duration of treatment. So it is close to 1, close to placebo after 1 year, but it is up to 2 or even 3 after 2.5 and 3 years of treatment. So constant increase of risk with the duration. Now, cardiovascular risk. This previous was gastrointestinal risk. Here is cardiovascular. The same story, and the drugs are absolutely the same. In first 6 months to 1 year of treatment, risk is either close to placebo or a little bit increased. However, after 3 years of treatment, risk is 4 times higher than risk in first 6 months of treatment. So with the duration, the risk increases significantly. We should not treat patients longer than it's necessary, particularly patients with osteoarthritis. That's what I'm speaking about here. So, what about type of drug? Now, here we are. Are COX-2 selective drugs better than the others, generally? These are results of GI bleeding rates that started to go down with the use of COX-2 selective drugs. And it was clearly seen that GI bleeding rates dropped significantly when we started to use COX-2 selective drugs more and more. The same is for GI perforations. Very clear results on many patients for a prolonged period of time of 1 decade or more. However, there are individual differences. And here, again, we can see 2 drugs, one highly COX-2 selective and other non-selective or very mildly selective, showing some difference in number of cumulative incidence of upper gastrointestinal events, which became significant after practically 2 years of treatment. However, these are all possible adverse events, including dyspepsia, which is the most common, and most of these adverse events are not dangerous, at least not very dangerous. If we analyze the most dangerous and most important adverse events related to gastrointestinal tract, then we will analyze severe acute bleedings, perforations, and obstructions. And if we analyze that, let's see the result with these 2 drugs. Here is the result. So perforations, obstructions, and major bleedings were with practically were practically with same appearance in both drugs, which tells us that we have to be very careful when we analyze the data, and the data are drug sensitive. They are not absolutely similar in the class. Now, let's see this analysis about cardiovascular safety. This is a risk of strokes. And here we have 3 non-selective drugs, and we have 4 COX-2 selective drugs. And let's see the green line, which is actually the line of placebo. And below this line is celecoxib, diclofenac, and meloxicam, which all are mild COX-2 selective drugs, including diclofenac, or mildly close to non-selective. It depends on the study. And then we have a red line, which is 1.3. Everything which is below 1.3 to placebo is considered not so dangerous. And as you can see, all drugs were below 1.3. So generally speaking, the risk of cardiovascular adverse events is not so high, particularly if you don't treat patient more than 6 months or 1 year. Okay, so that was it regarding the cardiovascular risk. Now, I would like to ask you, I would like to go back again to the gastrointestinal risk. And please tell me, what do you think? Should we combine non-steroidal anti-inflammatory drugs with proton pump inhibitors? Or we should not? I'm really sorry I can't hear your answer. But later I will have some questions, so maybe we could go through that in a few minutes. So first of all, let me show you the results of CONDOR study, CONDOR Trial, which was actually celecoxib versus omeprazole and diclofenac for at-risk osteoarthritis and rheumatoid arthritis patients. And this was analysis. Is one COX-2 selective, mildly COX-2 selective drug better than the combination of diclofenac, which was considered as non-selective, and PPI, proton pump inhibitor? Now, let's see the results. We had in my institute, we had close to 400 patients screened and more than 300 patients randomized in this study. That's why I'm showing the image of my institute again. So the general results was, as you can see on this graph, the cumulative incidence of GI tract problems was significantly higher after 120 days of treatment in the group which was treated with diclofenac plus PPI in comparison with group treated with celecoxib. Now, what was the difference? Let's see that. In this table you will see that gastroduodenal bleeding was rare in these more than 3,000 patients, and only 3 cases were seen in celecoxib and 3 in diclofenac plus omeprazole group. Actually, this was close to 5,000 patients, I'm sorry, and as you can see, it was similar and very rare. GI tract obstructions was 0. GI tract perforations was also 0. Small and large bowel bleeding was just 1 in each group. And clinically significant anemia was another story. But let's go to acute GI bleeding of unknown origin. It was 1 in celecoxib and 0 in diclofenac plus PPI. So it was quite a rare finding of each of these that are circled with red circles, and finding was very similar in both groups. So where was that difference? Let's see it. Here, it was here. We had clinically significant anemia of unknown origin, which was much more common in patients on diclofenac plus PPI in comparison to celecoxib. And we had clinical significant anemia due to unresolved possible GI bleeding, which was 5 times more present in diclofenac plus PPI in comparison to celecoxib. That is where difference was found. Okay, you can say, what is clinical significant anemia? Well, in this case, clinically significant anemia was difference in level of hemoglobin at the beginning and after the treatment period of 20 grams or more than 20 grams per liter. So you will, I think you think that that is a significant difference. And that was the only difference in these 2 groups. Now, the question is, why was mildly COX-2 selective drug better than non-selective plus PPI combination? Well, all of us who were involved in this study, we all thought that the reason is very simple. That the reason is that PPI is protecting upper GI tract, and therefore it makes non-selective drug equal to COX-2 selective, who is protective for upper GI bleeding, and at the level of upper GI tract we do not have any difference. However, since PPIs do not work in a lower GI tract, we believed that because PPIs do not work in lower GI tract, they do not affect the safety of GI tract in lower parts. That is the reason why COX-2 selective drug was better because COX-2 selective drug is protecting all GI tract and PPIs are protecting just upper part. That was what we assumed, and therefore we concluded that COX-2 selective drug alone, mildly COX-2 selective, is better than combination of non-selective drug plus PPI. Now, is that true? We will see. Practically, I won't get you an answer before the discussion. I will conclude now. So, my conclusions will be general. And first of all, I would like to say that both meta-analysis and randomized clinical trials and observational studies as well showed that COX-2 selective drugs and non-selective NSAIDs are associated with mild increase in risk of cardiovascular complications. And since we do not have rofecoxib anymore on the market, practically this difference is not significant between these two classes. It was not observed. And there are individual differences, but not major difference between the two classes of drugs. Regarding the GI safety, we can say that mildly COX-2 selective drugs showed better GI safety profile than non-selective drugs. And that is concluded in many studies. And use of PPIs could practically be associated with higher, and non-selective drugs could be associated with higher risk of GI bleeding in the lower GI tract. And it seems that continuous NSAID treatment in patients with active rheumatoid arthritis or spondyloarthritis could protect these patients from premature death because it stops inflammation. So these are the conclusions, and these are data that could help you to increase the quality of life of your patients, at least I hope. And now I'm ready to discuss with you. Practically, I hoped that we can hear each other, but it's not the case, unfortunately. So I'll have to read the questions that you prepared in advance, and I will try to answer them in the best way. Thank you very much for your attention. I hope you heard me clearly, and I was clear enough that you understood what I wanted to send you as a message. Now, let's see the questions before I show you some slides that I prepared for the discussion. So I will ask the technicians here. I have a supportive crew here, 3 charming guys who are helping that this works well, and they will show me now the questions. I can see the questions page 1 with 5 questions, so let me read it for you. First question is, if NSAIDs are recommended for patients with spondyloarthritis when their evolution is good under biological treatment? If I understood correctly, maybe the question could be reformulated in, should we treat patients with NSAIDs, spondyloarthritis patients, if they are good on biological drug, on a biologic drug? Well, that is a very, very good question, because you cannot find anything specific regarding this in the literature and in recommendations. Practically nobody is mentioning NSAIDs anymore when you see that biologic drug is recommended. Well, the question could be very simple. You should continue with NSAID unless the patient is good, is very good, particularly if he has minimal disease activity. Then you should stop the NSAIDs, because biologic is doing its job properly. And if you have minimal disease activity, in most of the cases you don't need regular treatment with NSAIDs. Maybe in some rare cases to give it from time to time, which is usually not dangerous at all. So that would be my recommendation. Now let's see the second question. Is there data for differences on efficacy among NSAIDs according to head-to-head studies? Yes, of course. Of course there are. I showed you many studies in this meta-analysis that I briefly showed. And all these studies practically have the results that efficacy in registry doses is similar. Of course, if you use low dose of one drug in comparison to high dose of another, then you can face different efficacy. But that is not a proper comparison. So general conclusion is efficacy is very similar of different NSAIDs. Third question, what is the cardiovascular safety among NSAIDs when it's used combined with corticotherapy in low doses, lower than 7.5 milligrams? Excellent question. I thank that colleague that asked this, because it's a very tricky situation. First of all, combination of NSAIDs with glucocorticoids is always dangerous, very dangerous. Of course, that higher doses of glucocorticoids are associated with increased level of GI bleeding or any other risk, cardiovascular risk, and particular risk of infections. And you have to bear that in mind. And therefore, generally, this combination should be avoided if it's possible. If it has to be used, then the lowest glucocorticoid dose possible should be used. And another comment of mine, in many studies you can see that 6.5, lower than 6.5 of prednisone per day, or lower than 7.5 or 6.5 is considered more or less safe. There are some new very good data that says that it's not true. So any dose of glucocorticoid is dangerous, particularly when it's used for a long time. And please bear that in mind. Now, the fourth question, what is the involvement of NSAIDs in cartilaginous destruction? Excellent question. To make the story short, there are many proofs on experimental animals, direct proofs that prolonged use of NSAIDs is associated with the increased destruction of cartilage. There are some anecdotal reports that it's not the case, but still, I would suggest you to be very cautious and to have in mind that prolonged use can be associated with increased damage of cartilage. What is the risk-benefit ratio in case of NSAID usage in elderly patients over 70 associated with cardiovascular disease? I apologize for those among you who are more than 70 and feel themselves very young. However, if you are over 60, there is an increased risk. Risk actually increases with age and not just jumps up after 60, but it increases slowly with age. And of course, in elderly patients, particularly those with cardiovascular disease, the risk of cardiovascular problems is higher than in younger patients. And we have to take that in mind, particularly if you use NSAIDs for a long time. So shorter usage is much, much better, much more safe in these patients than the prolonged one. Now, the question number 6. What is the maximum treatment duration in case of injectable NSAID? And what are the most common side effects? First of all, there is no maximal treatment duration defined when we speak about injections of NSAIDs. However, usually we consider that you should use injections in these first 3 to 5 days to speed up a little bit the efficacy. However, you have to bear in mind that there is no major difference between the safety of NSAID given orally, given as suppositoria, or given as injection. So that's proven, and that's why we should not think about better safety if we use injections or suppositoria in comparison to tablet or capsule. How about the association of two different NSAIDs in the same patient? Is it acceptable or not? No, it's not acceptable, because the increase in efficacy is very mild and increase in safety problems is very high. So the increase, for example, of risk of GI bleeding is 7 times higher if you use 2 NSAIDs at the same time. Don't do that. What is the profile of a patient that uses NSAIDs and does not need to receive PPI? Haha. Oh, that is a tricky question, because we didn't discuss the use of PPIs in general. You just saw the results that when you use PPIs, the problem with upper GI could be lower and the problem with lower GI could be higher. So let's leave this answer to this question later. However, regarding the profile, well, young patients, patients without any risk for GI bleeding, are of course the best profile of patients that we can treat with NSAIDs, including the PPIs, so we shouldn't use PPIs in these patients. But the question is, should we use PPIs in general? And I'll try to answer it in a few minutes. Now, the question number 9, what is the minimum duration of NSAIDs treatment on a certain molecule enough to define a failure of that molecule and decide to change it? To be very fast, 4 weeks for chronic inflammatory diseases. It could be even shorter for other diseases. But we consider that we should use full dose for 4 weeks regularly if we would like to define that this NSAID doesn't work in spondyloarthritis, for example. So 4 weeks is the time. And I have one question more. What is the recommended treatment duration of NSAIDs in rheumatoid arthritis? Well, I will be short. You know, NSAIDs are of not much use for the treatment of rheumatoid arthritis. So you should use them just as a supporting medication, just in case that you cannot give glucocorticoid at the beginning of the treatment, which are much better regarding the efficacy and inflammation. So practically you should avoid it, unless you are forced to use it at the beginning and or in the periods between 2 DMARDs, whatever the DMARD is, to stop the inflammation. Now, what is the recommended treatment duration of NSAIDs in rheumatoid? That was the question. I thought there was another one, guys. Yes? They will show me, I hope, in a second. If not, could we go back to... Yeah, okay. So, CONDOR Trial, the proportion of bleeding is equal, but the clinical significant anemia is due to bleeding. Yes, it is. If that is a question, I suppose it is. Yes, the significant anemia was associated with bleeding, which was in either confirmed or not. But that was considered as a consequence of bleeding. Now, if I could ask gentlemen who are helping me to go back to discussion. Thank you very much. I hope we have time and hope you have time for just a few minutes more to try to resolve the PPIs problem. So I will ask you a question. I'm so sorry you cannot answer directly. So, are PPI protecting or damaging upper and lower GI tract? And I will offer you several answers. First answer is, PPIs reduce the risk of bleeding from both upper and lower GI tract. The second, PPI reduce the risk of bleeding from upper, but do not change the risk of bleeding from lower GI tract. And the third answer is, PPIs reduce the risk of bleeding from upper, but increase the risk of bleeding from lower GI tract. Ha! Now, I'm so sorry I cannot hear you. What is your answer? Is it 1, 2, or 3? Generally, and most commonly, people believed that the right answer is answer number 2. So, they reduce the risk of bleeding from upper, but they do not change the risk of bleeding from lower GI tract. Is it so? Let's see. I will show you some results that came up after the CONDOR study. And actually the right answer should be number 3. So PPIs, according to these studies, reduce the risk of bleeding from upper, but increase the risk of bleeding from lower GI tract. Why? Now, these are studies on animals. We cannot do this on humans. However, it was clearly shown after the publication of CONDOR study that PPIs alone, in comparison to placebo, increase the damage of mucosa of lower GI tract. So this is injury score of mucosa, which was much higher when the animal was treated with PPI in comparison to placebo. Now, again, the intestinal damage score, which was significantly higher if the animal was treated with omeprazole in comparison with placebo, or animal was treated with lansoprazole in comparison to placebo. Everything was proven by biopsies. And let's see here the 2 biopsy samples, those samples of an intestine. As you can see, upper image is where animals were treated with naproxen and placebo, and the lower image is animals treated with naproxen plus omeprazole or lansoprazole. So as you can see, one drug that is considered relatively dangerous for the GI tract, like naproxen, didn't show significant damage of lower GI tract when it was used alone, I mean with placebo. But the risk, and not just the risk, the actual damage was so, and it was significantly higher if naproxen was used with PPI inhibitor. What that tells you? That tells you practically that PPI inhibitor is increasing itself the risk for lower GI bleeding. Now, how is it possible? Why a PPI inhibitor should increase the risk of lower GI tract bleeding? Sounds a little bit crazy. You cannot easily find the clue. But actually, one of the clues, one of the answers was found. And it is here on this slide. I hope you see it. The answer is microbiota. The bacteria in the lower GI tract. PPIs are changing the microbiota of the lower GI tract. And with that change, the total aerobes and enterobacteria are significantly increased in these animals that were treated with PPIs in comparison to placebo. And that change of microbiota resulted in increased bleeding from the lower GI tract. Is it proven? It could be that it's just a coincidence that we had PPI and changed microbiota. And it could be that actually PPI directly increases the bleeding, not microbiota. But it was proven that it's microbiota. How it was proven? In this study that I showed you, maybe we can go back to this slide, please, guys. Yes. So it was proven by simple transplant of microbiota of the animal that was previously treated with PPI to the microbiota, to the guts, to the intestine of animal that was not treated with PPI. And with the transfer of microbiota after the PPI is gone from the animal that was previously treated, it resulted, this very microbiota resulted in increased level of damage of intestine in the animal that was not treated with PPI but got the same microbiota. So it tells us that most probably PPIs are harmful for the lower GI tract in comparison to treatment without them, and the reason for that is the change of microbiota of this part of GI tract. And that raises the question, should we use PPIs to protect upper GI tract at all? Or it's better to use COX-2 selective drugs without PPIs? That question should be addressed in some very good design study in the future, and I hope it will. And with this, I would like to thank you very much. If anyone is left listening to me, I would like to thank very much those who are left. And I hope it was clear, and I hope it was interesting enough, particularly this PPI part, which is not so very well known, at least that I know. So thank you very much for your attention and your time.